So tuberculosis is a disease of great antiquity. Evidence of tuberculosis are available in the bones found in mummies in the Mediterranean. There's mention of tuberculosis in Rig Veda, where it was called yakshma. It was also Greek called it as thysis, Latin called it as consumption, and it was also known as white plague. Hippocrates, who is considered as the father of modern medicine, felt that it was hereditary. Then it was left to Robert Koch, a physician in Göttingen, to describe this as a bacterial infection after infecting 94 guinea pigs, 70 rabbits, 44 mice, and 9 cats, and isolating the same bacteria from each one of them. However, when he traveled from Göttingen to Berlin to speak to Professor Virchow, who was the chairman of pathology, he was thrown out of his room. So on 24th March 1882, he spoke to the physiologist of Berlin. The paper was subsequently published on 11th April 1882 about the etiology of tuberculosis. Paul Ehrlich already had a method for staining the bacteria. Zeal and Nelson worked on it, and by the next year, they had a stain known as Zeal-Nelson stain, which is still being used in 2023. The bacteria was labeled Mycobacterium because in liquid culture, it grew as a pellicle, which is a feature of fungus or mycology. So it became Mycobacteria, bacteria which looks like a fungus. Culture on Lowentzen-Jensen media became the gold standard, but the culture was slow, taking weeks, and low in sensitivity. So smear examination became the standard of diagnosis. Unfortunately, the smear, though it is cheap, it is quick, it is easy to perform, but it is not sensitive. And the bacterial load must be 10,000 bacteria in the sample before you can detect it as positive. This was the state of affairs in 1985, more than 100 years subsequently, where the deaths due to tuberculosis were the commonest, while funding for this was the least. Around this time, the Doctors Without Borders also alerted that there is a gathering form of blood-resistant tuberculosis and indicated that the techniques used by WHO and other authorities have failed to control the disease or prevent emergence of MDR tuberculosis. During that time, there were 500,000 MDR tuberculosis. 2 million deaths, 10 million cases, and DOTS, which is directly observed treatment short term, was to detect 70% and cure 85%. Therefore, waiting for treatment. The Director General of WHO, who had said that tuberculosis cannot be controlled. Please mute your mic. Tuberculosis cannot be controlled in the industrialized countries unless it is sharply reduced as a health threat in developing countries of Asia, Africa, and Latin America. And with the advent of HIV, tuberculosis and AIDS became a deadly duo. It was in 2015 that all heads of states in the United Nations agreed that time has now come to shift from control to eradication. So an End TB project was started. This End TB project had the commitment from the government, which would have stewardship and accountability, and they'll monitor and evaluate. Build a strong coalition society and community.
Indians, they are very deep.
Protect
Is very deep.
Human rights, ethics, and equity. And it had 3 pillars. It was postulated that in developing countries where the incidence was more than 100 per 100,000, for tuberculosis to be controlled and eradicated as a public health problem, the incidence had to come down to less than 10 per 100,000 population, which is what is there in the developed countries. And for that to happen, the decrease from 2015 has to be 17% every year, so that by 2035, it would become less than 10 per 100,000. Not completely eradicated, but no longer a problem, no longer a public health problem. The treatment for tuberculosis, drug-sensitive tuberculosis, has remained unchanged for the last 40 years. It is 4 drugs to be given for 2 months, that is known as the intensive phase, followed by 2 drugs to be given for 4 months, which is the continuation phase. New attempt was made to shorten this from 6 months to 4 months. And the results indicated that it was equally effective in drug-sensitive tuberculosis. This was also published in MMWR and have recently been adapted by WHO for drug-sensitive tuberculosis in persons over 12 years of age. For drug-resistant tuberculosis, South Africa has shown that using 3 oral drugs, bedaquiline, protinamide, and linezolid, you can change the complexion of the hopeless nature of XDR to nearly cure for all the patients after 6 months of treatment. This has been a landmark change in XDR treatment. We have recently reduced the number, the dosage to be given of linezolid, which is toxic to a certain extent, but instead of 600 milligrams twice a day, now it's to be given 600 milligrams once a day for 26 weeks.
Patients with drug-susceptible tuberculosis are typically treated with a 24-week rifampin-based regimen, but adherence can be challenging, and trials have shown high clinical cure rates with some shorter regimens. A new trial examined whether a strategy involving shorter initial treatment would be non-inferior to standard treatment for rifampin-susceptible TB. In this phase 2-3 multi-randomized open-label adaptive non-inferiority trial, 674 patients 18 to 65 years of age were assigned to either standard treatment with a rifampin-based regimen for 24 weeks, or a strategy involving initial treatment with a novel 5-drug regimen for 8 weeks, with treatment extended for persistent disease and post-treatment monitoring with retreatment for relapse. The standard 24-week regimen comprised rifampin and isoniazid, with pyrazinamide and ethambutol for the first 8 weeks. Non-inferiority was assessed in 2 strategy groups with different initial 8-week regimens. One was based on high-dose rifampin and linezolid, and the other on bedaquiline and linezolid. Both also included isoniazid, pyrazinamide, and ethambutol. 11.4% in the rifampin-linezolid group, and it was similar in 3 groups, with a 24-week rifampin-based regimen.
And place the first set of questions. So as you see here, Pillar 1 was integrated patient-centered care and prevention. Pillar 3 is intensified research and innovation. And now that means what is required is Pillar 2 to be activated. That would mean that there should be bold policies and supportive system in place so that the new integrated patient-centered approach that we will be describing now, as well as the innovations that are taking place, are quickly adapted as the standard. Seven clinical standards for treatment or management of drug sensitivity pulmonary tuberculosis. One is every individual, child and adult, with symptoms and signs compatible with pulmonary tuberculosis should undergo the necessary diagnostic investigations. That means tuberculosis is no longer a clinical diagnosis alone. you have to do necessary diagnostic investigations before you label a patient as tuberculosis. Second standard is all patients with symptoms and signs compatible with pulmonary tuberculosis should undergo bacteriological tests. Third, all patients with pulmonary tuberculosis should be treated with an appropriate regimen as recommended by WHO and/or national guidelines. There was a study done once in India where they inquired the regime that private practitioners were using after making a diagnosis of pulmonary tuberculosis. And it is reported there are 59 versions of the treatment regime. So it has been the efforts of WHO, then to be followed by national guidelines to make standard treatment available nearly free of cost to all patients diagnosed as suffering from tuberculosis. The fourth standard is that all patients initiating treatment for pulmonary tuberculosis should be provided by health education and counseling. This is a new indication because it was noticed that many persons who start treatment because they are symptomatic, once they improve after 1 or 2 weeks, please mute yourself. Provide health education, they stop treatment after some time. So adherence to treatment is very important. It is also important for treatment monitoring should be conducted to follow the patient's progress, support patient with drug treatment, assess treatment adherence, detect and manage adverse effect early, and detect the emergence of drug resistance. At the end of the treatment, a set of tests should be performed for each patient to ensure that he has now fully recovered. And finally, for each patient with pulmonary tuberculosis, a set of public health actions should be conducted. So these are the 7 standards which have been internationally agreed upon that we should use these standards wherever we are treating pulmonary tuberculosis. For the first one is that a focused history should be taken, and it should take history of contact as well as whether drug sensitivity was done of the person who had been infected and from whom we might have possibly got the infection, whether the patient has suffered from previous TB, whether there are symptoms and signs of pulmonary tuberculosis. The whole history should be taken in detail. The known symptoms of tuberculosis include cough, hemoptysis, fever, night sweats, fatigue, loss of appetite and loss of weight, and in children, failure to thrive and decreased playfulness. The comorbidities include malnutrition, HIV infection, diabetes mellitus, chronic kidney disease, liver disease, and alcohol abuse. It has been noticed that in India, persons who die from tuberculosis are mostly malnutritioned. So that's why government has then decided to give monetary support to all cases of tuberculosis so that they can have nutrition, they can have better nutrition. In screening, up till now, we have been waiting for the patient to get sick and come to the hospital. The tendency now is to do active case finding. WHO has suggested that 4 symptoms can be used as symptom screen: fever, cough, weight loss, and night sweats. If a person has fever for more than 2 weeks, cough, weight loss, and night sweats, then that is known as symptom positive, and further investigations should be carried out. They have also included that it is recommended to get a chest X-ray done, and the chest X-ray should be digital X-ray, which is then analyzed by artificial intelligence, looking for hotspots in the lungs. These hotspots would indicate that there is place of activity, so that further investigations should be carried out in those who have hotspots in the lungs.
TB creates a heat map of the patient's lungs and displays an abnormality score on a scale from 0 to 100. The CAD for TB abnormality score is available within 1 minute. A high abnormality score may indicate tuberculosis, and the patient may undergo further testing and treatment. The CAD for TB results can be shown on any device like a tablet, personal computer, or your mobile phone. This way, CAD for TB helps in early detection of tuberculosis. TB creates a heat map of the patient's lungs and displays an abnormality score on a scale from 0 to 100.
So once we have
the CAD for
symptom
TB
score and CAD positive, the next step would be to collect an appropriate sample. And the most appropriate sample is a sputum sample. When a patient presents to a health clinic, the spot sample should be taken. Spot sample of the sputum should be collected on the spot. And in early stages of infection, it is a good practice to give a tube, a plastic tube, to the patient to take it home and sleep with the tube, so that when next morning, when the patient gets up and clears the throat and the bronchial tree in which secretion would have collected, he would then bring out the sputum, and that should be collected, and that is the early morning specimen, which is likely to be positive because it represents a longer duration of collection of the respiratory secretion. But you can get this sample only if you have given a tube to the patient, so that he has the tube with him when he gets up in the morning and clears his throat. What is to be done with the specimen that is collected? Since the time of Robert Koch, smear microscopy was the investigation which was carried out. But smear microscopy is not very sensitive and would need at least 10,000 bacteria to be present. Therefore, WHO now recommends that instead of smear microscopy, we should do molecular method for detection of tuberculosis. You can have the second set of questions now. So WHO has recommended 5 molecular methods which can be used instead of smear microscopy. 2 methods are recommended where HIV is prevalent. One is from the urine, which is lateral flow lipoarabinomannan. Lateral flow lipoarabinomannan is very useful Lateral flow lipoarabinomannan is a test which is done on the urine of a patient who is HIV positive to find out whether he is excreting a remnant of the cell wall of Mycobacterium tuberculosis. So this would be useful only in case of tuberculosis, only in case when a patient is HIV positive. In ordinary persons who are not HIV positive, this is not sensitive enough. This is not sensitive enough for the bacteria to be picked up. The other method is TB LAMP, which is loop-mediated amplification, and that has a sensitivity of smear microscopy. So because of these reasons, normally it's not a good idea to use these two unless in this specific situation. But with drug resistance, if we want the molecular methods to be done, one will be gene expert, the second one is TrueNat, and the third one is moderately complex automated nucleic acid testing. One method which has been developed in India is TrueNat. The advantage of TrueNat is that it is manufactured in India, it runs on batteries. Since it runs on batteries, it can be used at any place and it doesn't require constant supply of electricity. The disadvantage is that it is only it needs 3 steps for the test. First would be to isolate DNA. Second would be to test this isolated DNA to find out whether Mycobacterium tuberculosis is present. And once Mycobacterium tuberculosis is present, then to detect whether rifampicin is present or not. Rifampicin resistance is present or not. So it needs the technician to be robust and well trained. A simpler test which was made by CIFID is CBNAT, cartridge-based nucleic acid testing. This cartridge-based nucleic acid testing is also known as Gene Expert. The Gene Expert is single-use cartridge. You open the cartridge, place the sample in it, place it in the container, and in 2 hours' time, you get 2 very good and very important information. The 2 information you get. Ravish Pandey, please mute yourself. Ravish Pandey, please mute yourself. So the 2 important information that you get is whether Mycobacterium tuberculosis is present and whether it is rifampicin resistance. It was found to be useful not only for smear positive tuberculosis, but also for smear negative tuberculosis. And subsequently, when it was tested with extrapulmonary samples, then it was found to be the best method available for extrapulmonary tuberculosis also. In India, our colleagues from Hinduja Hospital had carried out an investigation involving number of samples like tissue, lymph node, fine needle aspirate, pus, abscess, synovial fluid, etc. And they found good results. So Dr. Camila Rodriguez in Hinduja Hospital published these results, and subsequently it was also confirmed by colleagues from CMC Vellore. A meta-analysis later on indicated that though the specificity of the test is good, in possibacillary tuberculosis, gene expert is suboptimal. Since over 40 million cartridges had been sold of Gene Expert, the company made a new cartridge and made it available at the same size and same cost. Now this cartridge is known as Gene Expert Ultra. Instead of 131 bacteria that it could detect, it detects 16 bacteria. So it is 8 times more sensitive in the lab. This was due to a number of changes that were made in the cartridge. The cartridge sides remain the same, but inside molecular methods, new targets were incorporated, melting curve was incorporated, the PCR reaction was doubled, and it could detect 16 bacteria. As a consequence, it became suitable not only for pulmonary samples, but also for possibacillary samples like TB meningitis, patient samples from children, as well as genital tuberculosis. In samples from children, recently it has become suitable to examine even stool examination because children have a habit of swallowing their sputum rather than producing sputum. This advantage was seen in the field with clinical samples where Gene Expert Ultra outperformed culture and Gene Expert. So the third standard was that we should use the standard treatment. The standard treatment, as I told you, has remained stable for the last 40 years, which is 2 months of 4 drugs and 4 months for 2 drugs. And recently, WHO has agreed that 4 months treatment could be given to children above 12 years of age. And in children who are not suffering from life-threatening infection. But this is based on presumption because you are looking at only rifampicin resistance or rifampicin sensitivity, and then you are presuming that INH is also sensitive and there is no monoresistance. So the presumption is that if rifampicin is sensitive, assumption is INH is also sensitive. And if it is not so, and INH is monoresistance, and now we know that INH monoresistant exists, then during the continuation phase, for 4 months, the patient will receive only rifampicin. On the other hand, if rifampicin is resistant and INH is sensitive, then since we would be treating this patient as MDR case, then the benefit of INH, which is an excellent antimycobacterial drug, would be lost, and the patient will be given more toxic drugs. Next generation sequencing from South Africa has indicated that INH resistance in tuberculosis is one of the first mutation to occur. As you know, all resistance in tuberculosis are consequence upon mutation in the target gene. And INH mutation is the first mutation that occurs. Again, it indicated that there are 2 sites in which mutation for INH occurs. INH is a prodrug. INH is converted into its active form by catalase enzyme, and mutation in CATG gene at S315 to T would make it irreversible. So there'll be high level resistance to INH. But if there is mutation in the promoter of INHA, then low level of INH resistance would occur. So all the next generation sequencing indicates that CADG gene mutation arises before rifampicin mutation in all lineage, and INH monoresistance exists much before rifampicin resistant occurs. Therefore, there was an editorial in which Max O'Donnell suggested that mutation conferring resistance to INH occur before resistance to other drug and then goes on to develop MDR tuberculosis. INH resistance predates rifampicin resistance. Phenotype of INH monoresistant is a precursor of MDR and requires intensified diagnostic and therapeutic interventions. And he suggested that routine testing of Mycobacterium tuberculosis for all relevant drugs should not be regarded as costly extra, but rather as critical step for overall drug resistance TB control and elimination. To be fair to the decisions that were taken, there was computer modeling which indicated that if you detect rifampicin resistant alone, then you make a difference of about 30% in the patient's treatment. But if you have to do INH resistance also, then you make only 4% difference. But subsequent work in Peru indicated that when a person has INH resistance, then the treatment failure and death is more than if there is no resistance. It was also seen in Durban that INH monoresistance was associated with worse clinical outcome compared to drug sensitivity tuberculosis when given standard treatment. It was also seen in southern Mexico that INH monoresistant had higher probability of treatment failure. And a meta-analysis indicated that treatment of INH monoresistance with first-line treatment resulted in suboptimal outcomes and could contribute to development of MDR tuberculosis. In India, it's been noticed that resistance is about 20% or so, 23% or so in the isolates. Recently, in 2022 report had indicated that after examining in 2021, they examined 1.9 million samples. 86% of the patients were suffering from drug-susceptible tuberculosis. 7% had monoresistant and 7.5% has MDR tuberculosis. On the 24th of March 2023, a TB report from India 2023 was published, and it indicated that TrueNet is more than 3.4 million TrueNets have been tested, and CBNet have been used. First line line probe assay, which had indicated that 78.8% are both INH and rifampicin resistant, but INH monoresistant was 7.1 and MDR was 7%. They were also tested for second line LPA, which indicated that fluoroquinolone resistance was present in 29% of cases. So the report indicates that those which were identified in 2021 as drug-sensitive TB, 85% has completed treatment, 4.2% died during treatment, 3.6% were lost to follow-up, and treatment success in public sector was 85%, in private sector was 87%. And they noticed that they had 15,923 INH monoresistant samples. In view of the prevalence of INH monoresistance, WHO has recommended that for whenever INH monoresistant is suspected, then you should add a fluoroquinolones to the regime. In 2021, WHO also released for diagnosis their assessment of 4 new tests. The advantage of these 4 new tests were that they would simultaneously report on Mycobacterium tuberculosis, but also report on INH and rifampicin resistance. Most of them had multiple targets for Mycobacterium tuberculosis, making them more sensitive than the existing methods. And because both INH and rifampicin genes were being probed, they would report both on INH and rifampicin. WHO own slide indicates that BD-MAX had a detection limit of 0.5 colony-forming units per ml, being the most sensitive, and would report on resistance if 6 bacteria were present. When we compared the 4 new methods available from BD-MAX, from AHRO, from Bruker, from Roche, we came to the conclusion that BD-MAX, which is a closed system, had a liquid handling system. For most of the 85% of the isolates, you would need to do only BD-MAX because it will tell you whether Mycobacterium tuberculosis is present and INH and rifampicin sensitivity. So by using one test, you would be able to detect in a central location the sensitivity, the presence of Mycobacterium tuberculosis, and the sensitivity. For decentralized purposes, SD biosensor based out of Manesar has also got a cartridge-based system. And report on both INH and rifampicin. So now when you use any of these systems and then you classify a person as INH sensitive and rifampicin sensitive, then you're treating them with confidence. For health education, the 4 key points are that there should be structured and comprehensive educational program as an integral and essential component of the management of pulmonary tuberculosis. Educational program should be age-specific, gender and culture sensitive, delivered in the local language and extended to mothers and families of households. Education should be delivered by professionals who are competent in the relevant subject areas and trained to deliver educational sessions. Educational material and technology support used to deliver them need to be evaluated in the sitting specific context. And the topics are also mentioned, what needs to be covered. Then the next one is to monitor. And since the treatment is either 4 months or 6 months, adherence is very important. There's also to monitor for adverse events. Hepatotoxicity is commonest side effects. Ethambutol has effect on color vision and therapeutic drug monitoring may be essential in specific cases. At the end of treatment, that is 6 months of treatment, there is a list of tests which has been recommended that needs to be carried out to ensure that the person has now recovered. And to sweeten adherence and to encourage persons to come forward, there is public health initiative also needs to be taken. Government of India has created a website known as Nikshay. It's a software where everybody who treats tuberculosis needs to upload the patient's detail and the reason or the evidence that a person is having tuberculosis. Consequent upon registration, patient will directly receive a sum of money as nutritional support, and he'll get free treatment for the duration of the treatment. The treating physician on information will get some initiative, would get some incentive, and at conclusion, when he informs about completion of treatment, would get another incentive. Field workers also have some incentives added. Recently, Nikshay Mitra has been started. Nikshay Mitra are donors who would then volunteer to take care of patients, and not only their nutritional needs, but also their vocational training if need be. So this is a comprehensive treatment of drug-sensitive tuberculosis. It would mean that if there is no resistance, then only one test is required, while in case there is some resistance, then you might have to culture. And if at this moment, about 18 drugs are available, they have been classified into Group A, Group B, and Group C, depending upon their effectiveness. And it's been suggested that the treating physician should choose from Group A first and have at least 4 drugs to be given simultaneously. And if 4 are not available from Group A, then Group B, and only Group C should be used when, because of resistance, members from Group A and Group B cannot be used. So once the culture has been done, then you have a choice of doing phenotypic MIC, but 18 drugs are available, and phenotypic MIC for many of them are not been standardized. So it's been suggested that we should then use next generation sequencing, which will then be able to probe the 32 genes which code for resistance to 18 drugs that are available. So by using next generation sequencing, after the bacteria has grown, we would then be able to, in a weeks to 10 days time, we would be able to get a comprehensive report on whether the gene for CATG gene, FABG, or others are wild, that means no mutation, and that therefore meaning sensitive, or mutation, meaning that there will be resistance. The traditional methods which were used for diagnosis in the past are no longer recommended. They have been relegated to be used for monitoring response. On the other hand, molecular methods are not recommended for follow-up. Molecular methods which are based on detection of DNA should not be used for follow-up, because molecular methods detect DNA and cannot differentiate between dead bacteria and living bacteria, while smear and culture by quantification would indicate whether mycobacterium is multiplying or not multiplying, and therefore the staining method as well as culture is recommended to study the response and not for diagnosis of the patient. There are at least 4 different regimens available depending upon what drug resistance is encountered, and all of them should be evidence-based so that you should know whether these drugs are sensitive or resistant. In conclusion, I would like to say that in 1882, when people were traveling by horse cart or bullock cart, smear microscopy was used to detect Mycobacterium tuberculosis for the first time. In 2023, now when most of the persons have aspirations to travel by Mercedes rather than by bullock carts, we should not be using robot cars be using more sensitive methods. And as I indicated, that culture would detect 10 to 100 bacteria. Gene Expert will detect 131 bacteria. Gene Expert Ultra will detect 16 bacteria, and BD Max will detect 1 bacteria. The limit of detection of TrueNet is higher than limit of detection of Gene Expert, and between is more than that of culture. So it lies in between. Therefore, one of the molecular method should be used rather than smear microscopy for case finding. It's time to work together to end tuberculosis now. I thank you for your attention.